This is Dr. Gazal. I'll be presenting to you a rare aortic valve case complication along with some hemodynamics. So in short, our case, he's an 80-year-old gentleman. He had aortic valve replacement with biprosthetic valve 3 times. He came for a regular follow-up in our echocardiography lab. So this is his left parasternal long axis view. We note here that his RV is a little bit dilated. His LV has a normal systolic function. LA is dilated. We can expect that because if you can see here, his rhythm is atrial fibrillation. This is the place for his aortic valve replacement. The valve is biprosthetic. And here we don't see anything suggestive of significant problem. So here we can measure his RVOT. The way to measure it is starting from high up, perpendicular line to the joint between the aortic valve and the septum. And here we got a measurement of 4.4 cm. The normal is up to 3.5 cm. So definitely it is dilated. So here we apply the color Doppler. We don't note any turbulence during systole, nothing during diastole. So the valve seems to be functioning very well. Color Doppler in mitral valve again does not show any significant turbulence. There is a tiny trace mitral regurgitation. So this is RV inflow view. We can see significant tricuspid regurgitation. The appearance is at least moderate. Applying continuous wave Doppler here, we can see a peak gradient of 97 millimeter mercury across the tricuspid valve, which is very, very high. This is a parasternal short axis view at the level of aortic valve. It shows again significant tricuspid regurgitation. Putting the CW beam here, we get a pressure gradient across the tricuspid valve of 128 millimeter mercury, which again note severe pulmonary hypertension, provided it is more than 2/3 of systemic hypertension during surgery. This is a left parasternal short axis view. It's almost at the level of mid-ventricle, a little bit basal. We can see a pap muscle here. However, part of mitral valve is shown here. What we note here is, the flat septum is only during diastole. However, the LV here appears perfectly circular during systole. So it goes with RV volume overload instead of pressure overload. So this should ring a bell. And it does not go along with our findings of pressure of 128 across the tricuspid valve. Just keep it in mind and let's see the coming slides. So in apical 4-chamber view, we note here that the RV is severely dilated, even it is larger than the LV, and it is sign of severity. RA definitely dilated. Again, as we mentioned, it can go with the atrial fibrillation. LA is a little bit dilated. Again, atrial fibrillation can be a reason. However, we just have to keep in mind other differential diagnoses. So just to quantify, we measured the RV at the basal area here, and we got a measurement of 5.4 cm. The maximum here we should get in a normal RV is 42 millimeters. This is a continuous wave Doppler in apical 5-chamber view across the biprosthetic valve. Here it shows that there is no significant gradient across the aortic valve. The maximum we got here, the mean gradient is 1.7, 1.5. So it's always below 2. However, just for technical problem here, we can see that, the tissue filter is said to be very high, or the rejection is said to be very high. So just to keep mind and just go back to the technologist and tell him or tell her that, they should fix their tissue filter. So this is the apical four-chamber view, and here we have a color Doppler across the tricuspid valve, and here we can note moderate tricuspid regurgitation. So this is the subcostal view showing the inferior vena cava here is definitely dilated, and here we can see some red color in the hepatic vein, which denotes that there is a reversal of the flow. We pulse this flow just to note the direction of the flow and the timing of the flow, whether it is systolic or diastolic. So a pulse wave Doppler across the hepatic vein, it shows systolic flow reversal, systolic flow reversal, and systolic flow reversal. So there is a systolic flow reversal with each beat. We have to keep in mind the differential diagnosis for this. One of the very common differential diagnoses we see here is severe tricuspid regurgitation. The other is AV dysynchrony, and we have to keep in mind some other differential diagnoses too. So again, in subcostal view, we note here that there is a well-aligned tricuspid regurgitation jet. We can see all components of tricuspid regurgitation jet. We can see here the flow conversion zone, the vena contracta, which is the narrowest area, and the jet area. So this is a very good jet for spectral Doppler. So putting our continuous wave Doppler beam across this well-aligned tricuspid regurgitation jet, surprisingly, we get a peak gradient on average of 32 or 33 millimeter of mercury, as we can see here, which is, contradicting our previous findings of 100 and 128 millimeter of mercury across the tricuspid valve. And again, it should ring a bell. Another notice here we can note is the tricuspid regurgitation jet density is not very dense compared to the inflow. So again, this is again severe. Not only that, if you look at the shape of tricuspid regurgitation jet, it's somehow parabolic. It's not early peaking. Again, this is again severe tricuspid regurgitation. So the question here, since we have contradicting measurements of tricuspid regurgitation jet, can we measure it some other way, utilizing some different jets? The answer is definitely yes. We have many ways to do it. One of the ways to do it is through measuring acceleration time through the pulmonary artery, just proximal to the pulmonary valve. Here we can note in this parasternal short axis view that there is some turbulence across the valve, the pulmonary valve, and there is physiological regurgitation jet. Here we can utilize the equation of mean pulmonary artery equals 79 minus 45% of the pulmonary acceleration time. And by plugging the value in, we got some result of 14 millimeter of mercury of mean pulmonary artery pressure. Keeping in mind that, again, mean pulmonary artery pressure equals third of systolic and two-thirds of diastolic pressure. However, if our systolic pressure would be 100 or 120, so this cannot be true, because one-third of 120 is 40 millimeter of mercury. So here we just got 14. So our systolic pressure cannot be 100 or 120. And this will align tricuspid regurgitation jet, as you noted before. We got a peak pressure gradient average 32 millimeter of mercury. So the RVSP, or the systolic pressure here, is the tricuspid regurgitation peak gradient plus the RA pressure. We don't know what is RA pressure. We can estimate the RA pressure. However, sometimes if we can directly measure RA pressure, well and good. Why to estimate it? The diastolic pulmonary pressure equals the end diastolic pressure from the pulmonary regurgitation jet, exactly here. So we measure it here, and then we add the RA pressure, and then we have the pulmonary artery diastolic pressure. So now putting everything together, starting from the flat septum during diastole and perfectly circular LV during systole, which is a sign of RV volume overload, not pressure overload, and the discrepancy between the multiple tricuspid regurgitation jet, we here can think of a shunt. So the best way to prove that we have a shunt is to measure QPQS, which is comparing the flow in the right side to the flow of the left side. We can do this simply by calculating the stroke volume in the LV and the stroke volume of the RV. So assuming that the LVOT is a circular shape, measuring the diameter here of 2.6, then we can plug it to the equation of a circle area, and then multiply this by the average LVOT VTI, we got a stroke volume of 80 ml. Doing the same thing on the right side, again assuming that the RVOT is a circular, and measuring the RVOT diameter of 3.4, and then calculating the RVOT area, then multiply it to the average RVOT VTI. Here we got 16. So the RV stroke volume is 145. It means that the QPQS is 1.8 to 1. So the RV flow here is 1.8 times more than the LV. So definitely there is a shunt from LV to RV causing this RV volume overload. So going back to the initial view of the parasternal short axis view, looking at the tricuspid regurgitation jet very carefully here, and then we ask the technologist or the technician just to tilt a little bit to check maybe there is a shunt from the LV to the RV. And guess what? Little bit of tilting, we can see the flow here is not coming actually from the RV, it's coming from the LV. This is the LVOT. Again, from LVOT to the right atrium. So the question here, is it LVOT or aortic root? So the answer can be simply, maybe the technologist is the only one who knows because he or she is the one tilting and they know they tilted, anteriorly or posteriorly. So no, this is not true at all. We can definitely know. Just if we put our M mode here, so here in color M mode, we note that the pressure gradient here or the flow jet happens only during the systole. If you note here, nothing during diastole or nothing significant. So the pressure gradient must have happened during systole. So there is a gradient during systole, nothing during diastole. And this only can happen in a chamber below the valve. Because if we say it's above the valve, the aortic pressure will be 100/80, 120/70. So there is always a pressure gradient. The diastolic pressure of the aorta is always higher than the RA pressure. So in that case scenario, we will get a continuous jet. However, only systolic jet, it means there is no significant pressure gradient in diastole. And, as we know that the LV diastolic pressure can be as low as 5, 2, 3. It can almost be close to the RA diastolic pressure. So there is no gradient between LV and RA during diastole. This is why we have only systolic pressure. So the answer here, yes, it is below the valve. So having the image freeze, we can measure the defect. And here we got a measurement of 5 millimeters. So the diagnosis here is very clear, jet body defect. So jet body defect is nothing but a very special form of BSD. It's if you will. Because the tricuspid valve, if you note here, is a little bit apically displaced. So there is a potential of having a defect between the LV and RA, LV and RA, through the membranous septum. The Gerbode defect was described as the name denotes by Dr. Gerbode in 1958. It's mostly congenital. However, acquired Gerbode was reported, and mainly due to endocarditis or traumatic, post-myocardial infarction, post-aortic valve replacement, as in our case. It is always a nice habit to measure some hemodynamics whenever we have a shunt or a defect, which we cannot usually measure in a normal patient. And here, because we always measure the systemic blood pressure of our patient before starting our echo study, we measured blood pressure of 135/70. So we know that the systolic LV pressure is 135, provided there is no significant gradient across the bioprosthetic valve, as we had seen earlier. So RA pressure here is the difference between the LV pressure and the gradient which we got. So the maximum gradient we got is 128, as shown here. So we measure RA pressure of 8 millimeter of mercury. And by knowing the RA pressure of 8 millimeter of mercury, we can then calculate the RV systolic pressure and RV diastolic pressure, which we mentioned earlier. So from that tricuspid regurg, adding 8, we get the RV systolic pressure. And from this end diastolic pressure across the pulmonary artery, adding 8, which is the RA pressure, then we get the pulmonary artery diastolic pressure. And as we noted earlier, that the mean pulmonary artery pressure is 1/3 of systolic plus 2/3 of diastolic. And then here we got 19, which is pretty close to what we got by measuring acceleration time. So just to have a complete picture of the case, here we have a transient Vgl Echocardiogram, short axis at the level of the LVOT, and this is the LVOT, and this is the RA. We can see some defect here. And by applying color Doppler, we can see a systolic flow from LV to the RA, just below the tricuspid line. Thank you very much. Hopefully you enjoyed the case.